Imagine looking at a familiar map. Say, like, a map of a city you know perfectly well, a place you've navigated your entire life.
Right.
Now imagine that day by day, the roads are just quietly being erased, the borders are shifting, the familiar landmarks are disappearing, and the landscape is fundamentally altering itself.
Oh, wow. Yeah.
And the wildest part, no one is talking about it. Like, you might not even realize it's happening until the map is completely redrawn.
I mean, it is profound and, frankly, a pretty unsettling image.
Yeah,
We rely so heavily on things staying where they are supposed to be.
exactly.
So when they don't, especially when we're talking about our own biology,
Yeah.
it's incredibly disorienting.
Welcome to today's deep dive. You reached out to us with a very specific anatomical question, and you really brought the receipts to back it up.
You really did.
Yeah, you handed us this stack of medical guidelines. We're talking patient leaflets and clinical updates from the UK's National Health Service, the British Association of Dermatologists, the Royal College of Physicians of Ireland, and the British Society for the Study of Vulval Disease.
It's a very comprehensive stack of research.
It is. And all of this material covers a chronic inflammatory skin condition called lichen sclerosus, or LS. Now, your specific question to us was, can this condition affect the perianal region?
Right, the area around the anus.
Yeah. But as we looked into your question, we realized the answer actually unlocks a much wider, often deeply misunderstood picture of a disease that affects up to 1 in 300 people.
And many of whom are, quite frankly, suffering in absolute silence.
Okay, let's unpack this. What exactly is happening to the body when we talk about lichen sclerosus?
Well, at a fundamental level, lichen sclerosus is a chronic inflammatory dermatosis.
Okay, so a persistent skin issue.
Exactly. To
Yeah.
break that down, it's a condition where the skin is basically caught in a state of severe ongoing inflammation. And while it can technically appear on the wrists or the torso, it has a highly specific predilection for the anogenital region.
Mostly in women, right?
Yeah, particularly in women and female children. The true prevalence is actually a bit of a mystery due to massive underdiagnosis, which we'll get into. But the clinical guidelines estimate it affects anywhere from 1 in 1,000 to, like you said, 1 in 300 people.
Which is not rare.
Not at all. It typically peaks in middle-aged women, around 52 to 60 years old, though it can absolutely strike in prepubescent childhood as well.
Let's get right to the listener's core question, though, because understanding where this strikes gives us a massive clue as to how it behaves.
Definitely.
So can this condition affect the perianal region, meaning the skin right around the anus?
The short answer is yes, absolutely. The medical guidelines use a very distinct anatomical term for this, actually. They call it the figure of 8 involvement.
The figure of 8, so we're talking about like a continuous loop.
Correct.
Yeah.
Imagine drawing a figure of 8 on the body. The top loop encircles the vulva at the front, and the bottom loop encircles the perineal and perianal skin at the back, looping right around the anus.
Oh, wow. So it connects them.
Yeah, the inflammation follows this specific pathway. And in severe cases, it can even extend outwards to the buttocks, or what we call the genitocrural folds.
Which are what exactly?
They're the deep creases of the groin. The data in your sources shows that in about 3 in 10 cases, the skin around the anus is heavily affected.
30%. Okay.
And in some rare presentations, it only affects that perianal skin, with zero involvement at the front.
Okay, but if the disease is encircling the anus and the vulva, I mean, those are areas of constant movement, right? Friction, bodily functions. What is that actually doing to the skin itself in that specific back loop?
The tissue essentially loses all its structural integrity. It becomes incredibly fragile and loses its ability to stretch.
Because of the inflammation.
Exactly. And because of that extreme fragility, the simple mechanical act of passing stools can cause painful splitting, tearing, and cracking of the perianal skin.
Oh man, so the skin is literally fracturing under normal daily pressure.
It is.
Wait, I want to stop and challenge something here, because the sources mentioned this is a major issue for children.
Yes, it is.
If a young child is brought into a pediatrician with severe constipation, and you're saying the root cause is an autoimmune skin condition, how does a doctor even connect those dots?
It's tough.
Because that sounds like a massive leap. You'd immediately assume, I don't know, they aren't eating enough fiber, or maybe they have a gastrointestinal issue.
It does sound like a leap, but it is a perfectly logical, albeit pretty tragic, behavioral response.
How so?
Well, in children with LS, chronic constipation is listed in the clinical guidelines as a highly common symptom. The mechanics of it are entirely behavioral.
Meaning they're doing it on purpose?
Basically, yeah.
Yeah.
The child attempts to pass a stool, the fragile perianal skin tears, and they experience severe, sharp pain.
Oh, I see. So they associate the toilet with pain.
Exactly. The child quickly associates the toilet with agony, so they begin withholding their bowel movements. And that withholding leads to stool impaction and chronic constipation. So if a clinician doesn't know to physically examine the skin for that figure-of-8 discoloration and tearing, they will just treat the child with laxatives and completely miss the root cause.
That completely reframes how we look at symptoms. The symptom is gastrointestinal, but the disease is dermatological.
Right.
It really highlights how easily this can hide in plain sight. So if a patient or a doctor is looking at this, what does it actually look and feel like? You might think pain is the main warning sign, but the sources are practically screaming about one specific symptom.
Oh, absolutely. The clinical texts emphasize that the primary hallmark warning sign occurring in an overwhelming 93% of cases is an intense, relentless itch.
93%, that's almost everyone.
Yes. And this isn't, a standard dry skin itch. It is notoriously worse at night, to the point where it completely disrupts sleep architecture and heavily impacts the patient's daily cognitive function and quality of life.
We need to look under the hood here. Like, why is the skin itching so badly and what is physically changing?
So early on, it might just present as nonspecific redness. But as the chronic inflammation persists, the underlying structure of the skin begins to fail.
Failing how?
The immune cells are essentially attacking the dermis, breaking down collagen and elastin. And those are the proteins that give our skin its thickness and bounce.
Right.
Because that scaffolding is being destroyed, the skin develops these pale, pearly white plaques. Eventually, the tissues become highly atrophic.
Meaning they thin out.
They thin out dramatically, taking on what a medical text describe as a cigarette paper or crinkled appearance.
Cigarette paper. That visual tells you instantly how delicate and translucent it is. But if the skin is that thin and the patient has an uncontrollable urge to itch, the math on that is terrifying.
A math is brutal. Patients inevitably scratch. But scratching skin that lacks a foundational scaffolding leads to instant trauma. The sources note this causes ecchymosis and purpura.
Hold on, let's translate that. Ecchymosis and purpura. Are we talking about like internal bleeding?
Essentially, yes. They are tiny blood blisters and larger pooling of blood under the surface.
Oh, wow.
The skin is so fragile that the sheer friction of a fingernail shears the microblood vessels underneath, alongside causing painful external fissures and open erosions.
So the body's protective barrier is basically tearing itself apart.
Yes, it is.
But it goes beyond just the surface, which brings us right back to that map metaphor from the beginning, the idea of the landscape erasing itself.
This is where we see the most profound consequences of untreated LS over months or years.
The structural changes.
Right. The constant cycle of inflammation, microscopic tearing, and abnormal healing causes severe structural changes. It leads to tissue fusion, which is medically termed agglutination.
Wait, how does tissue just fuse together?
Think of it like two raw, scraped knees pressed against each other.
Okay, ouch.
Right. The body is desperately trying to heal the open erosions, but because the entire area is inflamed, the body gets confused and heals the opposing raw surfaces together, bridging the gap with scar tissue.
That is wild.
What this looks like anatomically is the gradual resorption and eventually the complete disappearance of the labia minora, the inner lips.
They just disappear.
Yes. The clitoral hood can seal shut, effectively burying the clitoris entirely beneath a layer of scar tissue. And the entrance to the vagina, the introitus, can significantly narrow or even be obliterated.
The clinical sources literally refer to this ultimate loss of normal vulval architecture as the plastic doll appearance.
Yeah.
I had to read that line in the guidelines twice. That is a devastating clinical way to describe someone losing their anatomy.
It is a very stark medical term, but it visually conveys the complete smoothing over and loss of normal, distinct structures. However, the guidelines are very clear on a crucial differentiator here.
What's that?
Lichen sclerosus is strictly a condition of the external skin. It affects the vulva and the perianal region. It does not cross the mucosal barrier into the internal vagina, the cervix, or the inside of the anus.
That distinction really matters because the sources mention another condition, lichen planus, which can attack the internal mucosal tissues and cause internal vaginal scarring.
Exactly.
But with LS, the damage stops at the external skin. Yet even stopping at the external skin, the functional impact is massive. I keep thinking about an analogy for that loss of elasticity.
What comes to mind?
It's like a rubber band that has been left out in the baking sun for a year, It dries out, the structural integrity degrades, and if you try to stretch it even a millimeter, it doesn't yield, it just snaps.
That is the exact biomechanical reality of what happens to the skin in LS.
And when you apply that brittle rubber band reality to the entrance of the vagina, it completely explains why sexual intercourse becomes profoundly painful or even physically impossible.
Right, a condition called dyspareunia.
Yeah. The skin simply cannot stretch to accommodate anything, it just fractures.
And that fracturing leads to immediate pain, fear of future intimacy, and a massive psychological toll. I mean, the clinical guidelines explicitly recognize this psychosexual distress as one of the primary burdens of the disease.
If the body's map is being rewritten like this, who or what is holding the pen? Like, what triggers this destruction?
What's fascinating here is that the exact trigger remains elusive, but the strong medical consensus points toward an autoimmune mechanism.
So the body attacking itself.
Essentially, yes. Your immune system, which is supposed to be your defense network against outside invaders, misidentifies your own normal, healthy tissue as a threat.
Oh boy.
We talked about collagen breaking down earlier. The body is dispatching specialized immune cells directly into the skin to dismantle its own infrastructure.
It's like hiring a demolition crew to protect your house, and they decide the supporting walls are the enemy.
That captures the mechanism perfectly. And this theory is heavily bolstered by patient data.
What does the data show?
Individuals with LS have a significantly higher frequency of other autoimmune disorders, particularly thyroid disease like Hashimoto's or Graves' disease or autoimmune diabetes, where the immune system attacks insulin-producing cells.
Because we are dealing with a genital condition, I imagine the stigma and misinformation are just rampant.
Oh, they absolutely are.
The sources you provided are incredibly aggressive about dispelling certain myths right out of the gate.
They have to be aggressive because misinformation delays actual medical care. We must be categorical here.
Let's do it.
Lichen sclerosus is not contagious. You cannot catch it from a toilet seat, and you cannot pass it to a partner through sexual intercourse. It is not a sexually transmitted infection.
Good to know.
It is not caused by poor personal hygiene, hormonal imbalances, or a laundry detergent allergy. And crucially, it is not a fungal infection like thrush.
Which is a huge trap for patients, right?
Huge.
If you experience an intense burning itch in the genital region, the immediate assumption is a stubborn yeast infection. So people rush to the pharmacy, buy over-the-counter thrush creams, see no improvement, buy a different brand, and meanwhile, the structural damage of LS is quietly progressing.
Exactly. Misdiagnosis, even self-misdiagnosis, is the enemy of preserving the anatomy here. And the mechanics of the disease get even more complicated because of a specific physiological feedback loop called the Kopner response.
Let's break down the Kopner response, because this seems to be the engine driving the worst flare-ups.
It really is. The Kopner response is a phenomenon where mechanical friction, physical trauma, or chemical damage to the skin actually summons the lichen sclerosus to appear in that exact spot.
Or makes it worse.
Yes, or violently accelerates an existing flare-up.
So it's like a faulty burglar alarm. The friction of tight clothing triggers the alarm, but instead of sending repair cells to fix the irritation, the immune system sends an armored SWAT team that just starts trashing the local neighborhood.
That is the exact cellular response, yes.
Yeah.
Think about the unique environment of the genital and perianal region.
Lots of friction.
Exactly. Irritation from microscopic urine leakage, wearing tight, unbreathable clothes, or the constant friction from wearing incontinence pads or panty liners, especially if they contain synthetic fragrances, acts as the trigger for that burglar alarm.
That creates an absolutely vicious cycle.
It does.
You have an intense 93% prevalence itch, naturally. Human instinct says you have to scratch it. But the physical trauma of scratching triggers the Kopner response, summoning more of the autoimmune SWAT team to that exact spot, making the skin thinner and the itch even worse.
And if you're wearing a pad for a little stress incontinence, that friction is just ensuring the alarm never turns off.
It perfectly explains why the disease is so stubborn. The very symptoms it causes prompt behavioral responses from the patient that biologically accelerate the tissue damage.
Yep.
We have to talk about how to break this cycle, because leaving this untreated, just hoping it goes away, is not an option. The stakes laid out in the guidelines are terrifyingly high.
The stakes go far beyond the profound psychosexual distress, the painful sex, the chronic urinary issues, and the irreversible architectural loss. There is a very real, very serious oncological complication.
Cancer.
Yes. Untreated or poorly controlled, lichen sclerosus carries an estimated lifetime risk of up to 5% of developing into squamous cell carcinoma, which is a type of vulval cancer.
5%. I mean, for a disease affecting up to 1 in 300 people, that is a staggering number of potential cancer cases.
It is significant, and the mechanism behind it is chronic inflammation. When skin cells are constantly being destroyed by the immune system and forced to rapidly regenerate over and over again, the chance for a cellular mutation, a transcription error in the DNA, increases exponentially.
Because it's just happening too fast.
Right? That mutation is what leads to precancerous changes and eventually squamous cell carcinoma. Bringing the inflammation to a dead stop is the absolute medical priority here.
So how do we stop the SWAT team? What is the gold standard intervention here?
The unanimous first-line treatment across every clinical guideline is an ultra-potent topical corticosteroid. The specific molecule most commonly prescribed is clobetasol propionate 0.05% ointment.
Okay, a super strong steroid cream? But wait, I have to push back here.
Sure.
One of the most famous side effects of topical steroids is that they thin the skin. If a patient with LS already has cigarette paper thin skin that is tearing during bowel movements, aren't we just making it worse by putting a strong steroid on it?
It is the ultimate paradox of treating lichen sclerosus, and it is the root of a massive barrier to care known as steroid phobia.
Okay, explain the paradox.
Your logic is entirely sound for healthy skin. On normal skin, steroids decrease collagen production and cause thinning. But LS skin is not normal skin.
Right, the collagen is already under attack.
Exactly. The thinness in LS is caused by the autoimmune inflammation aggressively chewing up the collagen. The ultra-potent steroid penetrates the tissue and shuts down those hyperactive immune cells.
Oh, I get it. So you're stopping the demolition crew.
Yes. Once the immune attack stops, the skin can actually heal, rebuild its collagen, and return to a normal, healthy thickness.
If you are listening to this and looking at a prescribed tube in your medicine cabinet right now, this next part is vital. The guidelines acknowledge how terrifying this prescription is for a patient.
It's very scary.
You get this tube, you open the box, and you read the giant bold print warning label inside. Almost every strong steroid cream explicitly says, do not use on the genitals, do not use on broken skin.
Yep.
And yet, the patient is staring at broken skin on their genitals, and the specialist is telling them to apply it right there.
It induces massive anxiety. The patient is terrified they are going to permanently damage themselves. Furthermore, well-meaning pharmacists or general practitioners who aren't deeply familiar with the nuances of LS might see the prescription and actively warn the patient against using it.
It requires an enormous leap of faith to ignore a giant warning label on the medication.
It does. But the clinical consensus is crystal clear. The ultra-potent steroid is safe and strictly necessary for this specific condition when used correctly.
And if they don't use it?
Undertreatment driven by steroid phobia is cited as one of the primary reasons patients unnecessarily progress to permanent architectural scarring or vulval cancer.
So if a patient commits to using it, how do they navigate the dosage? How do they know they aren't overdoing it? Because the guidelines lay out a very specific tracking system, right?
They do. The safety protocol relies on two metrics. First is the fingertip unit rule. This is the amount of ointment squeezed from a standard tube that reaches from the very tip of an adult finger down to the first crease.
Okay, so just that top section of the finger.
Exactly. That unit is usually enough to cover the entire affected area. But the broader metric clinicians use to track safety is the 30-gram rule.
Break down the timeline for the 30-gram rule.
So a standard prescription tube of clobetasol contains 30 grams of ointment. During the initial intensive treatment phase to get the disease under control, that single 30-gram tube should last the patient exactly 3 months.
3 months for one tube. Okay.
Right. Once the inflammation is halted, the patient moves into maintenance mode, which usually means applying the ointment just twice a week. In maintenance mode, a 30-gram tube should last 6 months.
That is a brilliant built-in warning system. If a patient is burning through a 30-gram tube in 4 weeks, they are either applying it way too heavily or their disease is aggressively resistant and they need an immediate specialist review.
Exactly. It gives both the clinician and the patient a tangible way to monitor compliance and safety. Alongside the steroids, the guidelines also really pound the table on the generous daily use of emollients.
Which ties perfectly back into the Kopner response we talked about. If friction triggers the disease, the emollient is the physical shield.
Exactly the right framing. Unscented, plain emollients like petroleum jelly or specialized barrier creams hydrate the skin. But more importantly, they block chemical irritants like trace urine from ever touching the fragile skin.
Cutting off the burglar alarm before it can even sound.
Precisely.
This has been a truly eye-opening journey into a condition that really lives in the shadows. Let's recap the map we've traversed today. You asked us to look into lichen sclerosus and specifically if it could affect the perianal region.
And we found that it absolutely does.
We confirmed that yes, in about 30% of cases, you see that figure of 8 involvement circling the vulva and the anus, causing severe mechanical tearing and, especially in children, behavioral constipation.
Which is so often misdiagnosed.
Right. We unpacked the progression of the disease from that maddening 93% symptom of intense itching to the autoimmune demolition crew breaking down the collagen into cigarette paper, the subdermal bleeding, and ultimately the devastating plastic doll tissue fusion if left unchecked.
It's a heavy toll.
We broke down the mechanics of the Koebner response, where friction literally summons the disease. And we explored the absolute necessity of bravely overcoming steroid phobia to halt the inflammation using the fingertip unit and the 30-gram rule.
It is crucial to remember that this is a lifelong management process. There is no permanent cure, but with proper, diligent maintenance, the symptoms can be completely suppressed, and the irreversible architectural changes can be entirely prevented.
Which brings us to the most actionable advice from these guidelines. The NHS and the clinical sources strongly advise that anyone with this diagnosis should get into the habit of performing a self-check once a month.
Highly recommend this.
Get a handheld mirror, map out what your normal anatomy looks like, and actively look for any subtle changes, new ulcers, unhealing fissures, or thickened lumps.
The goal is to catch any of those rare but serious precancerous changes at the earliest possible stage.
It is ultimately about empowering the patient to take ownership of their biology and become an active participant in their own long-term care.
Absolutely.
Before we sign off, there is one final lingering realization from the data that I want you to consider. We mentioned earlier that the prevalence of LS is estimated between 1 in 300 and 1 in 1,000 people.
Right.
But the guidelines also explicitly state that these numbers are likely way off because it is so widely underdiagnosed. Mild cases are routinely dismissed as dry skin. But here is the statistic that changes the entire paradigm. 9% of lichen sclerosus cases are completely asymptomatic.
No maddening itch, no sharp pain.
Nothing.
In those individuals, the disease is often only found incidentally when a gynecologist or a dermatologist is examining them for a completely unrelated issue.
Think about the weight of that. We are talking about a condition where the body's map is slowly, quietly erasing its own borders. And because of the deep-seated stigma, the embarrassment of talking about genital health, and the assumption that physical changes are just normal aging or a stubborn yeast infection, people suffer in silence.
They really do.
Given those odds, someone you know, perhaps even you, might be living with this invisible structural change right now, completely unaware that the landscape is shifting beneath them.
It's a sobering thought.
It's a potent reminder that sometimes the most profound and permanent changes happening to our bodies are the ones we can't feel and the ones we are too afraid to name. Keep asking the tough questions, keep examining your own map, and we'll catch you on the next deep dive.